Hello, my name is Dr. Paul Richardson and I'm the Clinical Director of the Jerome Lipper Multiple Myeloma Center at Dana-Farber Cancer Institute in Boston, and it's my pleasure to be here at this year's ASCO meeting presenting on behalf of my colleague Dr. Melissa Alcina the results from our Panorama 2 study that we actually are presenting here as a poster presentation, updating people on the results of the study for the combination of bortezomib, panobinostat and dexamethasone. In this trial, which is a phase 2 trial, we looked to enroll patients with bortezomib refractory myeloma and treated them with the combination of bortezomib, panobinostat and dexamethasone. The rationale behind this combination is well established, with synergy being shown between histone deacetylase inhibitors and bortezomib in some very elegant preclinical work done by a number of investigators. In that same context, there have been a number of trials combining various histone deacetylase inhibitors with bortezomib, and using panobinostat as one example, phase 1 studies led by my colleague Dr. Jesus San Miguel showed really remarkable activity and excellent tolerability for this particular 3-drug combination. Based upon that and complementing ongoing phase 3 trials comparing panobinostat, bortezomib and dexamethasone to bortezomib and dex alone, we in this phase 2 trial sought to establish the activity of the 3-drug combination in the face of bortezomib failure. In other words, patients who were clearly refractory to bortezomib-based treatment. So of the 60 patients enrolled in a multi-center trial, we were very pleased to report previously that we saw an overall response rate of PR or better of 35%, and we saw that minimal response or better was in fact in excess of 50%, which given the heavily pretreated nature and refractory nature of these patients, we thought was pretty encouraging. The focus of this poster, as I said, led by my colleague Dr. Melissa Alcina, who was a key co-investigator on the trial, was to demonstrate what the characteristics of the various patients who did undergo treatment were in relation to their response. So what I'm very pleased to share with you is that Melissa's analysis demonstrates very nicely that in patients with high-risk cytogenetics, the response rates were remarkably robust. In fact, in high-risk cytogenetics defined as 17p deletion, 414 translocation or 1416 translocation, recognizing that the number of patients is relatively modest at 14 of the 60, we're able to demonstrate 43% response rate overall, PR or better, and for the minimal response or better, that actually rose encouragingly to 70%. So clearly this combination shows activity in high-risk cytogenetics. The other groups of patients we looked at were those who had progressed on bortezomib therapy versus within 60 days, and look at how they performed. And what we showed there, perhaps not unexpectedly, is that patients who progressed on bortezomib had a slightly lower response rate and progression-free survival than those who progressed within 60 days, but the results were not statistically significantly different, and that's perhaps not unexpected. It's important to note that all the patients were actually dexamethasone refractory, and so again, it was not clear from our analysis that the presence or absence of dexamethasone in their last regimen contributed meaningfully to any differences in responses, although there was a trend suggesting that immediate prior dexamethasone exposure was associated with lower rates of response than if dexamethasone had been used earlier. And I guess that's pretty intuitive, but I would stress that it did not overall impact on the response rates that we did by analysis, suggesting that the original response rate and progression-free survival data we reported actually are robust. Again, phase 2 trial, single-arm, multi-center, but we stand really, I think, quite encouraged by these results. Another piece of the study that we presented here at ASCO was that we looked at quality of life. And in the quality of life measurements, because obviously the tolerability of panobinostat is important, and it does appear to be manageable as a drug, although some of the side effects can be challenging, particularly gastrointestinal. What we showed was that actually in terms of quality of life measures, for those patients who responded, obviously there was a quality of life response improvement based upon their responsive disease, but overall, for all patients, there was not a major change in quality of life associated with the treatment, which, recognizing the limitations of a small single-arm phase 2 or limited phase 2, 60 patients, arguably not small, but moderately sized, we were quite encouraged by these results. So obviously, in terms of where panobinostat is going, this will very much hang on the results of the Panorama 1 trial, which is now complete, and results and analysis and final reporting of that study is anticipated later this year. And I think with these kinds of results from Panorama 2, we're very hopeful that panobenostat will show that it really does convey meaningful clinical benefit to patients, and look forward to, as I say, hopefully positive results from Panorama 1.